the size of the myoma as is claimed to be. It could just be a marginal drop in the size, rather drop in the volume. I'm much better off finding my plane of cleavage without any therapy pre-operative. Um,
Okay.
the reason is because we use vasopressin for installation in the capsule when we are doing our myomectomies laparoscopically. We do not believe in doing uterine artery ligation because, according to me, you're increasing the morbidity in the retroperitoneum, which is normal. It's a normal anatomy. So by doing this uterine artery ligation, which some of my colleagues like to do, I find it too much of a procedure that does not warrant any reasoning. And therefore, if you're quick enough and you're using vasopressin, you're using the harmonic to cut into the capsule, you can achieve good hemostasis very effectively. You can be careful with the way you coagulate the vessels and not the normal tissue, so that you're not damaging the normal myometrial bed. So the chance of uterine rupture also reduces by being selective with the use of electrosurgery.
Okay. Even doctor, if the patient is anemic, you won't give GnRH. This time, the goal of GnRH is to correct
It,
the anemia.
uh, well, that's of course, if the patient is anemic, it depends on how much her the bleeding and whether that GnRH can control the blood loss. It's not always it's going to work like magic and stop the bleeding completely. I mean, you can try whatever you want to suppress the bleeding because you want to increase her hemoglobin so that you can take her up for surgery. And sometimes the hemoglobin is frightfully low. You may even have to give a blood transfusion and then go ahead with the surgery. Yes, of course, it's not an emergency that one can wait and then build up the hemoglobin. So you can use
Okay.
GnRH for that. But if you ask me whether GnRH is good as to help me during my myomectomy, no, it doesn't help me during my myomectomy. I'm very good with my
Okay.
injection of vasopressin. It has been a tested medication since the times of Professor Sem, who introduced that in 1978. So since that time till now, it works very well, very effectively. Fortunately, in India, it's available at a very cheap rate, so we can use it like water.
Okay. I come to my last question, doctor. I believe you refer patient back to the attending after surgery. In post-myomectomized patient, would you recommend cesarean section during delivery if they get pregnant?
Okay, I don't do obstetrics for almost 20 years now, but I do believe that if the cavity has been opened, you should do an elective section. If the
Okay,
cavity
so
was
only when the cavity is open. Okay.
yes,
So with
because
that,
now
thank you so much.
because during pregnancy you can even measure the scar thickness where you have done the myomectomy, and if there's a problem, you can always act on early.
Okay. Okay. Thank you so much, doctor.
Thank you.
Thank you, Dr. Kabling and Dr. Prashant. Dr. Abhishek, we have one question related to what Dr. Kabling said. It's in the chat box. It says that, is it advisable to give pre-medications like Luprolide immediately before the scheduled surgery for DIE?
Okay, that's an interesting question. So I don't like GnRH anyway. So whether it's Lupron or Zoladex or anything of the sort. So I'm not a big proponent of them. Preoperatively, they have no value. It's a myth that it makes surgery easier or anything like that. So I don't really subscribe to that notion where you would give Preop Lupron to a patient because the side effect profile is too high, and there is no evidence to show that Lupron or Dynogest or any of the other available ones. Now there's oral GnRH which is available, which they don't have any efficacy over just standard birth control pills. If you want to keep a patient amenorrheic until you can schedule her for surgery. So that would be my indication to give medication pre-op. If she cannot get a date for surgery in the immediate future and she has to delay, like a pandemic, for instance, yes, so there are a lot of patients who have been on continuous OC pills till they could be scheduled to come into Mumbai to undergo surgery.
Thank you, Dr. Abhishek. Dr. Aranza Mendez, do you have any questions for Dr. Prashant and Dr. Abhishek?
Good evening, and I would like again to thank our speakers for a very informative lecture. I would like to direct my question to Dr. Prashant. Sir, we all know that the hardest part of doing a laparoscopic hysterectomy is the retrieval of specimen. Okay, and it's, as you mentioned a while ago, it's a personal choice actually where to extract the specimen, whether abdominally or vaginally. But being gynecologists, whatever we can do vaginally, it's best to do vaginally. So I agree on that. However, upon doing some reading, I found out that there are techniques wherein which proved to be successful, that they did laparoscopic supracervical hysterectomy, followed by vaginal extirpation of the cervix. Can you comment in this on this procedure? Have you ever done a procedure like that? Or was there any need for you to do something like that?
No, I've never done a subtotal hysterectomy as such and then left the cervix behind. There have been instances where the cervix was actually being obscured by the sheer size of the uterus. So once the uterine arteries were taken care of, we did a subtotal hysterectomy, parked the uterus on the side, and then you had better exposure to the cervix to do the excision of the cervix using the colpotomizer. So that way it was easier to do that rather than trying to struggle with the large uterus coming in the way of your vision. Technically, if somebody were to do a subtotal hysterectomy, how is he going to remove that uterus vaginally unless and until he opens up the vagina, which can only happen after he has removed the cervix. So there are people who may say, okay, we'll try and remove the cervix vaginally. It's their personal choice. But when you're doing everything laparoscopically, might as well get the cervix out also by the laparoscopic route, and then deliver it out through the vagina. Because if that uterus was high up, it would be difficult to pull it down vaginally. But you can always do the circumcision of the vagina and detach the cervix from its attachments via the laparoscopic route.
But have you had any case of there was difficulty in extracting the uterus from the vagina and you had to do abdominal extraction?
Yes, I said that by and large, if I can't do it vaginally, I would then employ the technique that has been described by the Changung people, which I showed you on the video, which Abhishek was removing through the umbilicus, because that is not allowing your tissue to fly around, which can happen with the morcellator, and B is because it is through the umbilicus, you can remove larger pieces of the uterus than you were to use through the morcellator, which comes from the side. And if you have to close the incision, which you must in a layered closure, when you closing the large morcellation portal, which could be 12 or 15 millimeters, it is very painful for the patient for a couple of weeks, because you're taking a suture through the external and the internal aponeurosis. So that could cause a lot of pain for the patient, especially when she walks. So per se, I don't like to morcellate. Is because it is a heavy duty instrument, and if you're not careful, you can have tissue flying around, resulting in parasitic fibroids. We are not worried about leiomyosarcoma being as high in incidence as claimed by the FDA, because even if you were to do a poll of the members of the PGES as to how many cases of leiomyosarcoma they have encountered in their life, I think it will be much less than the incidence ever quoted by the FDA.
Yes, I agree, sir. And
And
basically,
moreover, if I'm doing a hysterectomy or a myomectomy and I follow the FDA guidelines, um, uh, the fault is at several levels. When you make your incision in a patient who may be a leiomyosarcoma, you have already written down the death certificate of the patient because that incision itself, or with the use of the harmonic, you've got tissue flying around. So obviously there is spread of the disease already occurring. Second is when you have hysterectomized the uterus or myomectomized the myoma, you have parked it on the bowel, you have already upstaged the disease before you put it in the endobag. So how is this going to prevent spread by just putting it in the endobag? So FDA cannot answer that question.
yes, so it's still controversial, one controversial. Okay,
It's not controversial. The controversy is FDA.
yes. Okay, thank you, Dr. Prashant. Can I direct my second question to Dr. Abhishek? Sir,
Sure.
what bowel preparation do you use for patients who have who you plan on doing a bowel surgery, for example?
Yeah, that's a great question. Thank you. So all patients undergo bowel preparation. So at least 4 to 5 days prior to surgery, they are on a low residue soft diet. And the day before surgery, they're on a liquid diet. I use peg leg or Exelite the evening before surgery if it's scheduled in the morning. And yeah, that's it. She's their NPO from midnight before if my surgery is scheduled in the morning.
And any antibiotics? Do you give antibiotics?
Intraoperatively, we give antibiotic coverage, and because in India, if I do a bowel resection or a disc, there's a chance of an anastomotic leak. We give antibiotic coverage for 3 days post-operatively.
Thank you.
You're welcome.
Thank you very much, Dr. Aranza Mendez. Now I'd like to call on our third panelist, Dr. Tumipig.
Thank you for the comprehensive lecture, Dr. Prashant. I have one question. Before you invented the Mangeshikar uterine manipulator, what do you use for TLH?
In the initial part, we actually had, which I actually even brought with me to Cebu and Davao, where we did the LAVHs. We had come out with an earlier model, which was basically a straight rod that could bend with a little joint. So you introduce the rod into the uterus, and then there was a fixator by which you could adjust one rod to all lengths. And then we held it with the valsalem and tied it together with a piece of tape, surgical tape. So that was my initial entry into developing the manipulator, and which I even demonstrated in the Philippines. But that was a long time ago in the mid-90s. And at the same time, I stumbled upon the idea of using the vaginal tube. So I actually went to the hardware shop where we use these bathroom pipes, and we fashioned from these bathroom pipes a tube that can go into the vagina and be my colpotomizer. So then we changed our routine. I did not have that concept of passing the manipulator through along with the valsalem through the pipe. So we would take traction sutures on the cervix and have a rod going through the uterus, and then tape it to the traction sutures, and then pass the rod over it, the vaginal tube over it. So those were the initial inventions before we finalized the manipulator.
Yeah, thank you. So in centers where they do not have uterine manipulator, they can do that trick. Just a
Yeah,
rod and
yes,
then hold it with the valcellum and a vaginal tube. Suture the
yes,
cervix. Because
yes.
some centers do not have your very, actually, I'd like to take hold of that Mangeshikar uterine manipulator because it holds the cervix. It's very important when you do TLH. So currently, sir, you don't do any TLH without a manipulator.
No, we always use a manipulator, but
Okay.
sometimes it could happen that you may not be able to put in the intrauterine element. Then we don't put the intrauterine element. We only catch the cervix with the outer part of the manipulator. But sometimes we can put the manipulator, but the vagina is so narrow that you
Yes.
cannot put the vaginal tube in. But we still do the TLH, and there are variations for that because then you can identify the vagina and the cervix laparoscopically, and then you do the circumcision. So there are many ways to bell a cat, but the principle is always that you need to manipulate the uterus to keep the ureta out of your field of surgery, and also to facilitate, especially if the patient has had a previous C-section. I always give the example that even though there are laptops that are used by everybody, even if you put the laptop on a desk, you can work better than putting it on your lap, though the laptop was designed for being put on your lap. So similarly, when you put the vaginal tube in, it is then acting as a platform on which you can dissect the bladder very well, because that's the tube inside, that's the vagina and the bladder on top. So once I've got a rest on which I can dissect the bladder, so it gives me a firm area below where I know it's the vaginal tube. I know that the vagina is above it, and then the tissue that moves is the bladder. So I can hold the bladder and dissect it out from lateral to medial. So that way, I have a much better pass through the normal tissue without injuring the bladder. So the platform that is provided by the vaginal tube, it gives
Vaginal
me a
tube.
better dissection of the bladder in patients with previous C-section.
Okay. Thank you, sir. If
Thank
the patient has a narrow vagina, if she's nalipara, would you recommend doing a sort of episiotomy?
Yes, we give an episiotomy to do that, and this was an idea that was developed by Dr. Shrish for vaginal hysterectomy in mentally retarded women who could not control their periods. So there obviously the patients were virgins, so therefore he would, with the consent, do an episiotomy and then proceed with the vaginal hysterectomy. So we borrowed the same idea that if the vagina is narrow, make a good episiotomy. Don't have to be mini. You can make a big episiotomy and then close it after the procedure. It's fine, no problem.
Okay, sir. Thank you very much, Dr. Prashant. Okay, Dr. Abhishek.
Thank you.
Dr. Abhishek, can you hear me? Yes.
Yes.
Can
Yes.
you hear me?
Yes, absolutely.
Yes. You do your preoperative. Yes. Thank you for that very informative lecture. We learned a lot from it. You do your preoperative ultrasound. So you must have a diagnosis if it's deep infiltrating endometriosis that needs resection. Do you work with the colorectal surgeon in those cases?
Yes, 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 I do. I think medico-legally it's important, and my colorectal surgeon is very skilled, and we're working together now, so we have a good understanding of endometriosis, and we do try to go as conservatively as possible and kind of push the envelope toward avoiding a bowel resection as far as possible and trying to conserve as much rectum and nerve function as possible. So it's good that we work as a team. So there are two schools in endometriosis where there's one of the multidisciplinary team and there's one of the endometriosis surgeon. So the endometriosis surgeon is the one who can do everything, the bowel resection, the urethral reimplantation, everything by him or herself. And the team is where there's a whole bunch of specially skilled targeted towards endometriosis, which I believe in, which is being led by the gynecologist who is who has a good working knowledge of bowel, bladder, and extra pelvic disease. So that being said, it's not just the surgical team that is part of the thing. There is post-operative pain management. There is physiotherapy that's involved to deal with pelvic floor dysfunction. There are nutritionists. There are sex therapists. There are, of course, fertility specialists is another branch that we work with very closely. And, there's also thoracic surgeons to deal with thoracic endometriosis or diaphragmatic endometriosis. So it's not really just the gamut of gynecology, but it is led by gynecology. So we should be setting the example for the other specialties.
Yes. So in your endometriosis center, you have a complete set of multi-specialists. And
Yes.
the patients are referred there in that endometriosis center, including the nutritionists.
Yes, I work with a few, and because we offer services in a few of the hospitals in Mumbai to suit different insurance providers and different budgets for patients. So there are, most of the people we work with have already got credentials to those hospitals as well. So it's quite a comfortable little group.
Okay. So for shaving endometriosis, you do it alone without a colorectal.
Yeah.
So for example, you encountered some perforation, you do suture without the help of a colorectal.
Yeah. So urethra injury, or if there's an injury during shaving,
yes.
I need to reapproximate. Yeah, I suture that myself. But it's usually if I'm doing a discoid, then I call the colorectal to do the circular stapler part. The laparoscopic part is handled by me and Dr. Prashant. And also for the bowel resection, the colorectal needs to come in.
Yes. So for shaving, would you say that it's for gynecologists?
It depends how complete you are. Yes, it is for gynecologists. It's not for the colorectal. But there's no harm.
Yes, but suture.
There's no harm in calling the colorectal into the OR if this is your first couple of cases and you're not sure how to go and you want to kind of push the envelope a little, and at least to just kind of look over your shoulder and tell you whether you need to do a repair or not. Yeah. So for the repair of a defect in the rectum, interrupted stitches with Trio Vicryl is okay for me.
Okay, thank you. Thank you very much, Dr. Abhishek.
Thank you, my pleasure.
Thank you very much, Dr. Umipig. We have two questions from Dr. Aquino for Dr. Abhishek. You mentioned in one of your in your lecture that you had a patient who had a splanchnic nerve injury after you did the IE surgery on. You mentioned that this patient had bladder dysfunction. How were you able to manage this complication post-operatively?
Yeah. All right. So I will elaborate a little more on that. So before preoperatively, the patient used to give a history that she used to take 10 minutes to empty her bladder every morning. So the pain, the ability to compress the bladder physically to empty it was needed by her. So there was already invasion of those nerves. So when we did the resection, of course, it's not going to get corrected by doing the resection, because if the disease has invaded the nerves, I know nerve sparing is a very fashionable thing to talk about nowadays, but if the disease has taken the nerves, it doesn't matter how good you are, you cannot spare the nerves. So she was already counseled beforehand that she would encounter problems. So, and we had a urologist consult. One of the hospitals I work in has a very good urology department that also does a lot of neuromodulation for patients with incontinence. So they follow up with them. We have a very strong pelvic floor team comprising urology, neurology that are working with her. So they've started with alpha blockers conservatively. She's been taught to self-catheterize, and we are following up on that.
Okay, thank you. And in relation to that, Dr. Aquino also asked do you recommend doing a urethral stenting for patients with DIE?
So preoperatively, before surgery, no. If you are doing for DIE of the bowel, no. They come in the way. They don't become as malleable during surgery. If you suspect that you've injured the ureter during surgery, stent. It's always better to stent than to not stent. If you have a nodule infiltrating the ureter and you have to do a uretrolysis, you have to do a urethral reanastomosis, then stent. You need to bring your urologist in to stent the ureter and then cut out the diseased area and then do a end-to-end, or you do a reimplantation. And for a bladder nodule, no matter, I believe in stenting all bladder nodules, because even though you may be far away from the trigone, when you are pulling the nodule out, your ureter has a notorious tendency to make itself part of the equation and sneak in. So that injury is catastrophic. So it's always better to stent all bladder nodules.
Okay. Thank you very much, Dr. Abhishek. We'll accommodate the last two questions from Dr. Umitik also for Dr. Prashant. Dr. Aquino asked that if for patients with large uterus for TLH, more than 18 week size, what type of uterine manipulator do you use?
I use my manipulator for all uteri.
Okay, sir.
The one that I showed you is the one which has got multiple uterine lengths, so you can go into any size uterus. And most of the uteri that we get to do a hysterectomy on are always more than 18 weeks and above. I don't get normal size uteri in my practice because being a referral center, all the big uteri are being sent to us for doing the hysterectomies. When people start looking at large uterus, they get worried. But let me tell you a little secret that if you have a large uterus, it is easier to do a laparoscopic hysterectomy than you trying to do it on an 8-week size uterus, because everything is so well defined when your uterus is large. The vessels are big, and the areolar tissue around the vessels is enough to be blown away with the carbon dioxide. So your dissection becomes easier, and your isolation of the vessels, you don't do it selectively, it just comes to you. But if you were to try that with a uterus that is small, there's a lot of, it's like all the tissues are congealed together. So there's always going to be increased vascularity and more bleeding than in an 18-week size uterus, unless until you cut the uterine artery without really coagulating. And as I said, you have to have faith in your bipolar, because the bipolar is the best modality of achieving perfect hemostasis, so that if you really coagulate well, you should not even see any blood coming out from that vessel, because it has occluded it very well. By pressing on the handle, you can modulate the current around the uterine artery and then coagulate it. And if you feel that it has only surface dried, but you feel that it's still wet inside, spray a little water over this dried vessel and coagulate again, and you get the same vessel sealing effect as you would get with the N-seal or with the ligature.
Okay, thank you, sir. For patients with uterus or large uterus or those with multiple myoma, what would make you decide not to perform laparoscopic hysterectomy?
The sheer size of the uterus, if it is, it all depends on your experience. As you grow more experience, you can take bigger uteri. But I mean, I would go up to 32, 34 week size without a problem, as you saw the one that Abhishek was doing on the video. But it again depends on the size. It also depends on the lateral expansion of the uterus. If the uterus is not, say, globular, and then you cannot even put your instrument by the side of the lateral wall of the uterus, then I think it's better that you do an abdominal hysterectomy rather than trying to shuffle around, because there's no way that uterus will move if it has really spread laterally. So And so, even if you use a myoma screw, you may not get that uterus out of the pelvis. So if it is frozen into the pelvis, then you have problems.
How many hours do you usually operate for patients with large uteri?
Well, normally it takes around anywhere between, it depends on how, if there are no adhesions, etc. But if there are adhesions or you've got endometriosis, it may go up to about 4 hours. But sometimes within an hour or two, you should be able to finish your hysterectomy.
Thank you very much, Dr. Prashant. Last question for Dr. Abhishek. This is regarding the stenting, the ureteral stenting. For patients with uterosacral nodules, would you recommend to do ureteral stenting?
If there's no involvement of the ureter, as in even an extrinsic nodule on the ureter without a hydroureter, I don't recommend stenting. So if it's just uterosacral with barely any parametrial infiltration, then no. But I do recommend doing ureterolysis all the way up to, so you can lateralize the ureter far away from the nodule that you're going to excise is very important. And of course, if you do suspect that you've got an injury or a thermal injury, it would be prudent to stent at that time. Call the urologist in, tell them to put prophylactic stents, and follow up that patient very closely.
Okay. Thank you very much, Dr. Abhishek, Dr. Prashant, and to our 3 members of the board, Dr. Kabling, Dr. Aranza Mendez, and Dr. Umitik, for that very engaging discussion. So we now proceed to the next part of our program. I would like to call on Dr. Maria Rica Baltazar. She is the training